So I've been asked to cover the principles of management of infection in total knee arthroplasty. So the first thing is to have a very systematic approach to a prompt diagnosis. And most of us follow this method of using a clinical judgment examination, and then using blood tests, ESR, CRP, and then assessing the joint fluid, and if necessary, doing a biopsy. Now, it's very important to consider 4 factors in making a decision how to treat the patient. And the first is the knee, the stability of the implant, bone stock, soft tissue coverage, and the presence of sinuses. Whether the patient has comorbidities and is desirous of multiple surgeries, can undergo multiple surgeries, and the patient's treatment preferences are important. The bug is extremely important if you can find it, and its sensitivity, whether there are any systemic symptoms, whether these symptoms are acute, and the duration of these symptoms. And lastly, the team, its expertise, particularly a microbiologist, infectious disease specialist, and a plastic surgeon if necessary. Based on the combinations of these, you can decide which treatment option is most appropriate from these 6, and we look at them starting with debridement and retention of the implant. This can be done if the symptoms are less than 3 weeks, if the implant age is less than 30 days, if the implant is well fixed, there's no sinus, and at least sensitivity to one antibiotic is present. If not, you can consider a one-stage exchange, provided the soft tissues are good, the bone stock is good, it's not in an immunocompromised patient that you're dealing with, they're susceptible to oral antibiotics. You can use an antibiotic in cement, and if the surgeon is experienced in this process. If not, a 2-stage exchange is more or less a gold standard. Delayed implantation should be feasible if the anticipated functional outcome is good, antibiotics are available, and there's been no previous failure of a 2-stage exchange. However, if any of these factors are present, such as absence of sensitive antibiotics, if there's no soft tissue coverage possible, if there's severe bone loss which precludes a resection or a fusion, or a failed prior resection or fusion, if an amputation outcome is likely to be superior to a resection or fusion, and rarely necrotizing fasciitis. In these situations, one might consider an amputation very, very rarely. And if it's a no to all these points, then you can consider a resection, arthroplasty, or a fusion, provided the patient is fit for surgery and is ready to undergo surgery. Remember, they may need flap coverage. This was a patient who presented with an exposed spacer. You can see that, multiple scars, a resection arthroplasty with a plastic surgery flap, and a hinged knee brace. This patient had a total knee elsewhere for post-traumatic arthritis. Somebody had put in this fixed spacer for infection. And after 1 year of repeat negative cultures, we did a 2-stage revision total knee replacement. Unfortunately, still developed recurrent infection, and after 2 years of fusion was performed. And the last option is medical treatment if patients are unfit or not ready for surgery. Debridement is the key and consists of surgical, mechanical, and chemical debridement, excision of all necrotic tissue, implant, cement, synovium, and biofilm, followed by mechanical debridement with curettage and power reamers and high-pressure lavage. And lastly, chemical debridement with a variety of betadine, chlorhexidine, prontosan, or anything of your choice. In a 1-stage exchange, it's important to soak the joint in the antimicrobial, close lightly and compress, then re-prep, drape, use new instruments, preferably another OT, lavage again, and use a new prosthesis with antibiotics and cement. Many of these may require a hinge if the collaterals are excised or damaged, and may need long-term antibiotics. 2-stage spacers can be, a 2-stage exchange is done using a spacer in the interim period. These could be static or articulating. The static ones are a solid block of cement with a huge amount of antibiotics. An example, these can extrude or dislocate, sometimes cause severe bone destruction and even soft tissue damage. Articulating spacers could be pre-formed like these or formed from a mold during surgery, but these can dislocate, they can cause overstuffing or even fracture. My preference is for using autoclaved prior femoral components with a new poly insert along with a huge amount of antibiotic cement. An example of a spacer. Now, if the stemmed components are also infected and the canals are infected, then I would use cement dowels over a K-wire. If there's very severe bone loss, you can use stems along with the spacer or a rod and a static spacer. This is a patient with an articulating spacer post-op. We allow motion after a week, brace for 2 to 4 weeks, and weight bearing as tolerated. The second stage, timing, remains controversial and is based on a variety of several factors that need to be considered. Generally, implant removal is not a problem. And again, a thorough debridement is done at the second stage, followed by insertion of the final prosthesis with cement. The advantages of articulating spacers are that you can use large dose of antibiotics without systemic side effects. Some patients will refuse the second stage. It's a cheaper method, it's easy to revise with less bone loss, excellent pain relief. So treatment of infection is extremely challenging. The timing is critical, and any delay allows the biofilm formation and reduces the rate of success. So consider the patient, the knee, the bug, and the team available to you. Thorough debridement remains the key. DARE can be performed in early sepsis, one-stage revision in very selected cases, and generally two-stage revision with articulating spacers is the most preferred treatment option. Thank you very much for your attention.